Yeah, thanks, Kaz. So a bit about anesthesia, ABCs of anesthesia. Right now, I'm going to put lots of QR codes throughout the session. So feel free, there's the ABCs of anesthesia Facebook group and page. So feel free to like and sign up to those. And I'll constantly, that's one of the major ways I'll start advertising these things with more regularity, as well as posting up all the new videos and other things that we do. Because we've got a few things in the pipeline as well, and which will rapidly occur. The more time I spend in lockdown, the more of this happens. So that's probably a good thing. There's the ABCs of Anesthesia course for when you're about to do an anesthetic rotation. You can always get me at abcsofanesthesia@gmail.com. That's the website. Unfortunately, hacked a couple of months ago, but we're slowly rebuilding. Also, as a lot of you would know, YouTube, Instagram, and Twitter, we're ABCs of Anesthesia as well. And then we've got the ABCs Anesthesia podcast. And in the future, or even sooner, we'd love to have you guys on. If there's something that you guys have learned that's really interesting, or there's there's some stuff that you've learned recently, thoughts you've had, or maybe you've done an elective in somewhere interesting, or you're about to do that, we'd be really happy to have people on just to have a bit of a chat about whatever you're doing. And hopefully that will give you a platform as well to put good ideas out there.
So something that I really admire about Lahiru is when he's been doing this teaching stuff for 10 plus years. And he's always had this attitude of really donating all the profits. So, through the YouTube channel, through all these courses, every single dollar he earns, he donates, essentially. And it's really inspired me to kind of review, what we do with this excess money and really create a model where potentially we can provide a resource that people want and then use that opportunity that we have to then raise money for really important causes. So I guess, Lahiru, it'd be really interesting for everyone here to kind of understand why you started doing that in the first place. How did it all start?
Yeah. It's a weird thing. I think COVID hit, and I realized just all the different horrible stories happening about people losing jobs and just the inequality that was even expanding because of it. And at the same time, I was just listening to a lot of Sam Harris, and a lot of people were talking about effective altruism. These really amazing guys called Toby Ord and William McCaskill. And they really inspired me because they essentially put their money where their mouth is. They give a massive proportion of their salary, and they've started this thing called a giving pledge where they give 10% of their, or more than 10%, but they try to get people to give 10% of their salaries. And what I realized was, trust me, when you guys become doctors, and especially when you become specialists, you will earn far more than you will ever need to be happy by most metrics out there. And I thought, it is hard to part with money that you earn from doing a lot of work, but you get so much out of it. So yeah, we, pretty much since starting the ABC's channel, we've made about $50,000 from our courses, and we just give that away to Fred Hollis and other charities. Now, obviously, med school, all the med school stuff, that I remember what it was like to be in med school because I was always absolutely dirt poor. So all of our med school stuff is always going to be free. I don't really, I really just want to put that out there as good education. But yeah, all the other stuff that we do, all the passive income from YouTube and Vimeo, that just goes straight to various good charities. So that's what we're about. So just to get cracking, our format, we're trying to make it, there's no boring content, just lots of facts, lots of context, some insider tips as well, and practical advice you can action on your first day, and then robust frameworks you can build on over the years. And that's something I'm going to harp on a lot about. And also in our next sessions, everything will be built on the framework, so you can build on these and add whatever knowledge you create or received over the years, you can put onto those existing frameworks. Definitely use the chat. I'll answer those as we're going. It will also be great things to chat about and to outline the future stuff that we're going to present on. So definitely use the chat, make it interactive, ask as many questions as you want. And if you're embarrassed about a question, you want to do it anonymously, completely fine. Just do it directly to myself or Kaz. And hopefully common sense approaches to leverage your existing knowledge as well. Yeah, so what I found the problem with med school teaching, there's just so much to learn, and you don't have that much time in anesthesia, as we were talking about before. And you often aren't given the advanced stuff because it's thought to be too advanced. And I just don't believe in that. You're all smart people. This is just knowledge. It's not quantum physics, which very few people can understand, I think. So the way we're going to teach, almost nothing is too advanced to learn. We're going to show overall frameworks for approaching cases, and then share algorithms for solving problems. Definitely those will happen more in the future sessions. We want to give you the frameworks and algorithms, which are the vital structures necessary to attach your experience and knowledge to. And the aim of this intro session then, take you on an unfortunate patient journey and show you what you can do to learn and assist and impress in each situation. So direct you to resources to enhance your learning curve. So definitely the QR codes will be there, and I'll post this all up onto YouTube so you can always look at it later. And then pretty much, just more interactive sessions throughout the year. And so by the end of this session, hopefully you'll have a compilation of lots of good resources to learn more about anesthesia and, go through it at your own pace. Skills to learn and assist your bosses, your supervisors, your registrars, tasks that you can even do as a medical student or a junior doctor to assist the team, that you're aware of these. And this will inevitably impress your supervisor. That's not the point, but it hopefully will. You'll get good references because that's all part of the game, and get the job you want and live happily ever after. So what do we do? So this is one of the first questions we get asked, what do anesthetists do? Because I definitely wasn't really sure. And I definitely have an expensive cycle that I love taking out, writing, and I'm really terrible at Sudoku, but some of my mates are ninjas at this game. I used to take really nice conferences and holidays because life was very flexible with my career, but that's not everything. Kaz, what do you reckon? What else do we do?
So why don't we put it out to you guys? So you've all been around enough theatre and hospitals. What are some of the roles that anesthetists have in the hospital or even out of the hospital?
Actually, I'm just going to ask someone. Let's go. Vivek, what do you reckon? Have you seen much anesthetics?
Yeah, we don't have dedicated rotations, but I've been in surgery and like to spend some time. I think it's a bit of a joke, but anesthetists like to protect the patient from the surgeon. That's one of the roles.
Absolutely, we do. Sometimes to a bit of too much of an extent. Anything else? Have you seen us do other roles?
So we've got two.
Yeah.
Oh, sorry. No, go on, Vivek.
I'll pass on to someone else.
No, you can go on, Vivek. That's fine. Keep going.
Yeah, so, just managing the surgery. So pre-operative, helping with the patient, seeing if they're suitable for surgery is one of the main roles.
Yeah, fantastic. And so that's like the main thing, a lot of our bread and butter. Oh, sorry, Kaz, you keep going.
That's right. So there's a few more here. So we've got putting in the cannulas that no one else can do. Yep, willingly or unwillingly, that is correct. The acute pain service. Yep, that's exactly like a big part of what we do. And then putting people to sleep. Love that. Airway, pre-op assessment, trauma assessment, pain management, code blue airway management. And one's called into the psych ward. Yeah, that's happened as well. So I guess the overarching theme is we, in a lot of positions, we do navigate the patient through the perioperative process, and that can be pre-admission work, stuff in the theater, and then afterwards as well. I think to a degree, the whole idea that we protect the patient is really that, it's about the division of labor when you're within a team. Often the way we manage patients as surgical anesthetic and nursing staff is you kind of divide up those roles. And our job is essentially to make sure the patient is ready and that they can safely have the surgery. So regional anesthesia is one that I think wasn't really mentioned. So we do lots of blocks. It's quite a specialized technique that I don't really think anyone else really takes part in. Deteriorating patient, Lahiri and I were talking about this. So we are default the airway experts in a code blue, but as a registrar now, going to code blue, you actually realize that between you and ICU, you kind of form a leadership team in deciding how to manage that situation. And so Lahiri is a Australian Resuscitation Council instructor, and I think a big portion of the instructors there are anesthetists, aren't they, Lahiri?
Yeah, I think I definitely am. I mean, really, a lot of the specialties are fantastic. ED is so competent with so many things, and ICU have all that experience as well. But I also love the fact that part of our job is we become that because we'll go into this later, because of all the stuff that we give to people to put them to sleep and make them pain-free and still for the surgery. That just messes up everything else. So we just get constant practice fixing up the messes that we've created. And some of the messes that surgeons create, whenever they accidentally cut something and there's a bit more bleeding than you'd like, we just, that's just part of the surgical complication. And it's such a great team atmosphere that you just do time and time again when you're working with a surgeon that you respect, and things are going not quite right because it's a really complicated surgery, and you're just there working together going, hey, how's the blood loss going? Getting better? Fantastic. I'll give this, I'll give that. How are you feeling right now? It's a really interesting dynamic, and we get to be part of that.
Yeah, and I think the two last points there is research and teaching. So one of the big reasons I was drawn to anesthesia is I'm curious to see if you guys have the same experiences. Every anesthetic consultant you come across loves to teach, really wants to get you guys involved, and they're really good at knowing what level to pitch it to, and they're really good at getting everyone involved. And also, I think research that we do in anesthesia is it's very outcomes based. So there's less of this culture of doing research and getting first author publications for the sake of getting on the program. There's a little bit of that, and it's relevant, but there isn't as much of an onus. So it's really about good teaching, good research, and a lot of the meaningful work that the college does in research is through the clinical trials network. So, big multi-center RCTs that are often international.
Excellent. So let's get cracking with a few things. Okay, so it's your first day of anesthetic rotation. You meet the anaesthetist for orientation when a call comes through. A 60-year-old patient has arrived in ED with small bowel obstruction, and there's only junior staff in the emergency, and they need help with an IV access and arterial line. It's really chaotic in the room, and you can see the anaesthetist is unfamiliar with emergency. What do you do? Even as a medical student, what do you reckon you can do? I might just ask someone, imagine you're in that situation. Paula Devlin, what do you reckon? What could you do to help?
I guess just ask the anaesthetist what they need to get through this situation. So if they need materials, you can go source them for them. If they need drugs, you can source that. If they need an area clean or cleared of other people, you can talk to someone or highlight the NUM or someone to facilitate that, I guess.
That's fantastic. And I love how common sense that is. You just ask them what they need. You don't even have to predict it. You can just go, hey, what do you need me to do? And you'll slowly build up a lot of these recipes. This is what my consultant needs for IV access or arterial lines or ultrasound access or even intubation. Some of the best, would you say, Kaz, the best anesthetic reg would also be a fantastic anesthetic nurse, or even all of us would, because then we know each other's needs and our expectations?
Yeah, 100%. So I think even as a, kind of halfway through my training registrar, if there's a code on emergency theatre, I assume my job to get everything ready for example, say Lahiru, so that cognitive load's taken away. And, that really does then trickle down. So I've had excellent residents and medical students and big cases with very sick patients, and just the ones who know how to get stuff really quickly and get things organized. And I think anticipating the needs, as well as Lahiru was saying, is really key.
Fantastic. So we asked the consultant. So a lot of things that you could do, setting up for the IV cannula outline, and on the Facebook page, there's a whole bunch of setups on the Facebook group. Know how to prime an outline, IV line, and get that ready, and maybe even get the ultrasound scan. And knowing what the consultant will need, or you will need when you fail the first step, either yourself or someone else can get it for you. Knowing what that next step is really useful. And again, there's all part of these frameworks. Do you want to go through some of these, Kaz?
Yeah, excellent. So we're not going to, this isn't a tutorial on how to do IVCs, but I think there's some very simple things that are very useful when you're putting in a cannula that I just think it's really useful for you guys to know. So first and foremost, put on the tourniquet. And then I really like to teach my students to think about why you put this on. So the purpose of the tourniquet is to restrict venous blood flow back from the limb or the arm. So you really need to give it time to get enough venous backflow to cause engorgement of those veins. And you really need to do it tight enough that you also get adequate congestion. So you look, you feel, and then you look again. And the key thing is be patient. It takes up to a minute for some veins to become palpable. And then you really want to then increase blood flow to that tissue. So you get them to clench and unclench, tap the skin, you release lots of vasodilatory mediators like histamine and serotonin that cause vasodilation of those veins and make them easier to palpate and access. Apply warmth, you get kind of vasodilation from the warmth, make that arm dependent. So drop it down, get gravity to help. And really that, would cover what 98% of all cannulas you'll ever do. And a lot of people forget a lot of those steps when they find a cannula difficult. Also, there are various positions that you can put a cannula. And it really depends on what the purpose is and what the timeline is. So if the purpose is this patient is bleeding, they're unwell, they're septic, and they need fluid resuscitation, you really want to get a big cannula into a big vein. And the easiest big vein we know is the antecubital fossa. So you can go to either, usually ends up being the cephalic vein on the right, or kind of the medial branches, which can vary between the two. But then you think about if it's for the short case, if it's for a day of antes, if it's for something little, you think about what's going to be the most comfortable for the patient. So acute FOS, every time you bend your arm, it's going to get occluded, which means you'll have to get another cannula later. And you do something distally. So the back of the hand is really good because it's relatively out of the way. I find about 50% of patients say that this is significantly more painful. So the other area that you get really good at cannulating when you're in anesthesia or quick care is kind of between the two. So the forearm, particularly with an ultrasound, it's out of the way, the veins are much bigger and you can access them. And again, don't forget the feet. There are some great veins and a lot of people don't think about looking there. And, you know, it is relatively dirtier, but it's still a great access site, especially if you're struggling.
Actually, there's a really good question in the chat. For a standard cannula in the back of the hand, is it better to place the tourniquet around the forearm or the upper arm? And look, I've heard many things, and very, very good practitioners say both things. For my personal preference, I don't think that there's any benefit of putting it down lower. Essentially, if you put it lower, you don't have a view and access of the whole arm, in which case, you might not see enough on the hands, and you might need to go up on the forearm or the cubital fossa. And I want to have all of that visible in one time. And also, if you compress at the bicep level, or the arm level, or the humerus level, that compression can, essentially compress all the veins in that region. But if you do it around the forearm, because there's two bones there, there's a chance that you might not be compressing the veins that are kind of internal. So there's a thought about that. That said, you could probably use both and they'll be fine. It's not such a big deal. I might ask someone, has anyone used the blood pressure cuff trick? Anyone can jump in.
I've used the trick in the pre-hospital setting.
Oh yeah, what is that?
Septic patient, unable to open a vein. We just put the blood pressure cuff on her and inflated it up. Managed to get a very small cannula into her.
Yeah, nice. And we do that because with the blood pressure cuff, you can know exactly not to inflate it above arterial pressure. So you still have the artery blood flowing in, but you do get it up maximally above the venous pressure. So I found that can be helpful at times as well, amongst everything else that you might do. And obviously I've got a whole bunch of videos about cannulas, which we're just going to keep coming out, but that's one of the things that'll make your life as an intern so much easier. Go for it, Kaz.
Good. So the other aspects of this problem was putting an arterial line. So let's pick on someone. Someone had a really nice background and they were sitting outside. Romain, hey. Why would you put an arterial line in a patient?
I've seen it done when you need a more accurate blood pressure. So in settings like ICU. I'm not actually sure whether you can deliver things, but I see more also for delivering things.
Yep, so definitely. So we can, so the first part, yeah, we essentially use it when we want beat to beat blood pressure. So we want ongoing blood pressure, beat to beat, and it's often kind of can be quite reliable in certain clinical scenarios. We don't ever administer anything through an arterial line, and it can cause lots of risk of things like thrombosis, especially if they're, if it's a radial line and you have an incompetent ulnar artery, you can actually cause distal ischemia. What other reasons can anyone think of?
Potentially, if you need like serial ABGs, could you put in an arterial line?
Yeah, fantastic. So serial ABGs for serial sampling. So ICU do this a lot, and arterial punctures are really painful. I haven't had one, but I've had enough patients yell at me to know it's quite sore. So you put it in once and you have frequent sampling. So look, this is pretty complicated, and I think we'll do a video on this a bit later on. But essentially, the principle of both these techniques. So this is the top one is the arrow. These are both by Teleflex. So the top one is the arrow. This is what you tend to use in ICU and when the art line is going to be in there for a bit longer. So the basic principle is you puncture the artery with this yellow needle, and then you have this long wire, and then you thread the wire through the needle into the artery, and then you take the needle out, and then you pass the catheter over. So this catheter is a bit longer, and then you can suture it in at two different points. The quick flash, essentially the same principle, except it's all contained in one device. So this is what it looks like on the top left here. So basically you puncture the artery and then you slide this black thing down. I just realized you guys can't see my mouse. But you slide the black thing down and the wire goes into the artery, and then you slide the white catheter over it. And we use these a lot in theater because they're faster. I learned on these, so I'm very comfortable on these, but you generally wouldn't want to keep these in for too long. But then again, I think these new quick flashes have these wings where you can suture them on, so they've obviously addressed that problem. So
I love that. So in summary, essentially, if you do oscillometric or the blood pressure cuff, that's a historical blood pressure. It could have been as much as 2.5 to 5 minutes ago in theater, and even longer on the ward. If you've got an outline and you know every single beat, and that's why having an anesthetic is so incredibly safe, because you're really just monitoring every single beat of the heart. And yeah, repeated sampling is so useful. Big blood loss cases, massive fluid shift cases, really useful. And what I love about it is you're using this technique, which you'll hear about so much, called the Seldinger Technique, which essentially, if you've got a small tube and you want to place a big tube in there, you first start with a tiny needle, put a wire into that tube in the body, and then they call it railroad, but you just pass over that bigger tube over that wire, and for some magical reason, that will pass into the small tube in your body. And usually that goes well. So every single time it's gone really well. And that's the Seldinger technique. And we use it for so many things: CVCs, art lines, even advanced cannulas, like the rapid infusion cannulas.
Good. So who knows what these devices are? So what's the CVC, Luke Tucker?
I'm actually not sure.
That's okay. So if I told you it was a central venous catheter, would you want to have a crack at where we might put it in and what we might use it for?
Yeah, still not sure.
No, that's right.
That's okay. Anyone else?
Well, outside of the scope of anesthetics, probably for like a constant access for a permacath in dialysis.
I didn't hear the first part, but yeah, the permacath is quite a similar process concept. So Smriti said jugular vein, so that's exactly right. So the CVCs are central vein cannulae. So we essentially, catheter, I guess. So we essentially put them in when we want central access as close to the IVC as possible. So potential sites are the internal jugular, which is where you often see it in ICU. You can also go femoral, and then you just have a longer length of catheter that can come up to the tip of your inferior vena cava. And you can also do a subclavian, which is, so subclavian into the subclavian vein. And then there's variations of this, which is what all these other devices are. So the MAC sheath is essentially a massive, big catheter that goes into your IJ, and that's just really for large volume transfusion and fluid infusion. The RIC catheter, which is the bottom left one I have here, who knows what a RIC catheter is for? How about Adelaide, Dennis?
I was really hoping you wouldn't pick me for this one because I don't know what it's for.
That's okay. So RIC stands for rapid infusion catheter. Essentially, it's just a big tube in a big vein. So I've only done this once, so Larry, you could probably speak a bit more to this. But essentially, if you have a cannula that's already working, and let's say you've got like a 20 gauge in the cube force, which is pretty good but not great, and you're losing liters and liters of blood in a postpartum hemorrhage or a trauma, you essentially use the Seldinger technique, where you take the bung off the cannula, you thread a wire through, and then you use the scalpel to make that insertion into the skin bigger, and then you dilate, and then you put a bigger catheter. So the RIC catheters, they come in French, but the gauge comparison is about 8 gauge or 10 gauge, which is huge. And they're really great at giving large amounts of fluid or anything.
Yeah.
Anything else on that level?
It's pretty much just the magic stuff that all you need is to be able to get a 20 gauge, and then you can always convert that into a massive line. So if you're ever worried that you can't get a 14 gauge cannula in, just put a 12 gauge in and say, hey, pass me the RIC line, and then you can always convert it to a bigger device. Really useful to know, because yeah, the first time I did that was probably as a first or second year registrar. So even if you're a junior, you can, and you're calling anesthetics for help, you can say, look, I've got a 20 gauge in, you can convert it to a RIC, and you might actually remind the anesthetist that they don't need to go fishing around for a difficult 14 gauge, because you've got a very simple solution already there. So that's the most useful point of that. knowing that you can convert a 20 gauge into a 12 gauge beast of a line.
Good. And Sasha's, I think, just mentioned that I'm presuming in relation to CVCs that we can use it for vasopressor. So that's really good. So a lot of vasopressors like noradrenaline and inotropes, we like to give through CVCs for multiple reasons. So that's really good too.
Yeah, beautiful. Again, some QR codes to some of our videos, which again, being useful as in anesthetics especially, you end up doing lots of things like putting lots of cannulas, drawing up drugs, priming fluid lines, which means that when you, even as a medical student, you get to an arrest or a deteriorating patient, you can be really useful because you've learned some pretty simple techniques, which they don't necessarily drill hard on in other aspects of medicine. You know, on your gen med rotations, you're not setting up fluid lines necessarily. So you become very useful learning how to do these things, and very easy to ask and be aware of this, even when you're just starting out. And that's the art line setup. Again, we'll put this video up soon anyway. Okay, so let's get cracking. So again, we're just going to follow a patient journey and take out interesting points from this, and this will help guide us for our future sessions as well. So the patient needs an urgent laparotomy. The anesthetist is busy inserting the lines. How do you do a patient assessment? And what is a sick patient assessment? And does anyone have any thoughts on that? I think I may just give the answer. I'm just going to ask someone random, and again, safe place, just have a go at this. This is just a really broad question. Harrison Lucas, what do you reckon? How do you do a patient?
So I think you just popped up the answer before, but essentially anything when you go to like a review a patient, just doctors A, B, C, D, E. So
yeah, fantastic. And why is that? And that's not your normal assessment, is it? Like that's like a sick patient assessment. What's a normal patient assessment?
I think you just start off with like an endobetogram is like what most doctors say. So just the well or unwell patient from the end of the bed. And yeah, then you just airways, breathing, circulation, make
fantastic.
Sure that's all okay.
And so I exactly do that. And I think all of us do that. When we look at that patient first, like I was just on the COVID ward round on Monday, and literally I just look at the patient and go, are they sick and might they need to go to ICU, or are they not sick and I can just relax? And then if they're not sick and I need more information, I go into that usual thing of history, examination, investigations, but exactly what you said, if they're sick, I really need to do the doctor's ABC. And why is it, you're on roll here, why is it that we want to do doctor's ABCD and not history, examination, investigations necessarily?
I think it's to not delay patient care, especially if it's a life-threatening situation. You want to get the most senior people there as quickly as possible.
Fantastic. Okay, good. And so this is what we're going to do. As we go through these sessions, you're going to see this real distinction, the fact that normal assessments are history, examination, investigation, but they don't really get you to treatment very quickly, like you said. So what we want to do is, if they're sick, we want to identify problems and solve them immediately, regardless of whether we have a diagnosis or not. You do not need a diagnosis to treat. And that's what I love about anesthetics, because we're often with patients deteriorating, I just solve problems and think about diagnoses later as definitive solutions. Excellent stuff in the chat. Good. So the point of the ABC assessment, as you mentioned, find a problem, manage a solution, and go through each of these systems systematically, because that's what the life-giving forces really are. Your airway, your breathing, your circulation, and other stuff. And then also dictates the urgency in our context as well. So I thought we might just go through a few things. So airway, like I'm just going to, again, a lot of this is common sense. I want you to just forget medical stuff. Think about common sense things you can do. Now, airways are often really just a lumen that needs to be patent, and they become unpatent or obstructed because of stuff in there, or because of swelling in the wall or compression externally. So if I was to tell you that there was a whole bunch of blood or saliva in the airway causing, stridor, when you look and listen to the airway, you can hear obstructive sounds. I might ask Isabel, what do you reckon? What would you do to fix that problem? There's blood or something in there.
Yeah, I reckon I'd try and suction it out if I could, or remove it somehow. Exactly.
Fantastic. So suction is one of those things we always check before every anesthetic, and that will be sort of a mainstay in clearing the airway. Because you're on a roll, what happens if I've got a massive post-thyroidectomy patient, And I don't know if you've seen any of these, but they always have the risk of a bleed in the neck. And that bleed can then cause stridor. What do you do?
So there you're pretty scared.
Yeah,
I think you have to cut open their suture and attempt to like stop the bleed or
well, absolutely. And you're exactly right. You want to cut open those sutures. And the interesting thing is this is again common sense. You've got this massive amount of blood accumulating, compressing externally. So the solution or immediate solution before they obstruct and essentially don't have an airway is to release that obstruction, whether it's, and you'll always see a suture kit or suture removal kit near the bedside. Superficial sutures get cut, deep sutures get cut from the strap muscles being tied, and that relieves the pressure temporarily. Again, you're just temporizing the situation while anesthetics and surgery are coming there to definitively solve the problem in theater. That's exactly right. And we can go through a few more of these things, so airway, obvious stuff helps. If they've just got a bit of soft tissue obstruction, a jaw thrust, head tilt, improving the position, maybe putting a Gadella nasopharyngeal. These are all things that medical students can absolutely do. And then we do similar things with the rest. So breathing, essentially, I always follow this mnemonic. If you're ever in that setting in an exam, you're thinking, oh, what are all the things I need to say about breathing? You simply say, I'd look, listen, and feel for signs of impaired breathing or respiration. And I think of rates mnemonic. Rate of breathing, auscultation, tracheal deviation or tug, effort of breathing, and SATs. And that's what we teach in our ALS course, but it covers most of the higher yield stuff that we can get information from. And like with everything, if you have any problems with rates, I might ask someone, what can you do? So let's say your SATs are low and the patient looks like they've got more effort of breathing. Sorry to pick on you, Kai Ting Ho. What do you reckon? What could you do?
So I guess you can start with simple measures like giving the patient oxygen.
Fantastic. Oh, yeah, Anne?
Oh, so as titrated to the oxygen saturation. And if that doesn't rectify the issue, then you consider more. So I guess you can start with a nasal prong and then start going up with like a Hudson mask. And then if that still doesn't rectify the situation, then it's a consultant call to have a more definitive airway.
Fantastic. What I like about what you did there was you told the whole story of what you do. I told you decrease SATs, effort of breathing increase, and you gave me a whole picture. I would progressively treat this patient by giving oxygen, start with nasal prongs, Hudson mask, non-rebreather, and then you might even go as far as putting a Liddell bag, tight-fitting face mask to give 100% whilst calling for help. That's a complete answer, and that's the kind of answers that I would expect my students to give. So that's great. And then let's keep going. So let's say circulation. Say your blood pressure is low, your heart rate is fast. What are some simple things you could do for this patient to help with that? I might ask Kieran or Nadia.
I guess if their blood pressure is low, heart rate is up, I guess you can consider giving them fluids. Again, you'd probably want to make sure that that's going to be safe for them if they're not already like fluid overloaded.
Beautiful. So you look at the assessment, see they're actually undervolumed, and simple things, because you know that by treating that fluid loss, if they deplete, you temporize measures while you're trying to find a solution. Fantastic. And again, there's far more complexities with this, but that's how we basically go ahead. Disability is GCS and, again, complex stuff, but always take a glucose there, because one day you'll be there taking the glucose, you'll get a reading of 1, which is very, very low, and they'll essentially save the day for you. And then exposure, because you really want to see the whole patient to see all the other things that could be going wrong. I think that pretty much.
I think a lot of this stuff probably sounds really basic to you guys, and the reason we put it in is, it is basic. It's a foundation of what you do every day. And when you start to be interns, and when you start doing your training intern rotations, you'll see junior doctors respond in med calls, and there's a I think because we were taught the well patient assessment so much in med school to do history, examination, investigation, get assessed on long cases, your OSCEs are all short cases. No one actually really assesses you on how to do this. And this is every single med call and urgent clinical review and code blue you will ever do. And, that is actually like 60% of your job as an intern. So it seems really easy, but thinking in this framework will allow you to essentially ameliorate most problems you'll come across until you can have someone there to escalate for help.
Excellent. So I've just done a bit of a patient assessment thing for more comprehensive anesthetic patient assessment. And we'll definitely have a section just on the patient assessment for anesthesia as well. Okay, what is the point of an ample history? I might ask someone else. Harmai, what do you reckon? What's the point of it? Firstly, are you familiar with the ample history, and what do you reckon the point of such a short history is?
Sorry, I'm actually not too sure what's an ample history.
No, that's right. So it's like this real focused history where you just go, what are the allergies? What are the medications they're on?
All right. Yeah.
Past medical history, last meal, and what are the events? So really not the full comprehensive social history, family history, et cetera, et cetera.
I guess to definitely rule out any drugs, allergies or anaphylaxis they're going to have, medications, especially blood thinners, anticoagulations, because it will be very important. Yeah, and meals, last meal to prevent aspirations during the surgical procedure. Yeah, that's really good. Like you really simplified that in a good way, because there's only a few things that really affect my anesthetic in a major way. Allergies, if they're on blood thinning medications, really is the biggest thing. And then last meal for aspiration. And then a few other things, like if they have severe cardiac disease, I want to know about that. But you don't need too much of a detailed history, especially in the urgent situation. So we stabilize with doctors ABCDE, and then we take an ample history, especially if we're rushing up to theatre, as in this case. Anything more to add there? Your mic.
I'm muted, sorry. So now this patient's in theatre, they're getting their small bowel obstruction operated on. So they need an anesthetic. So what is the purpose of anesthesia? So Emma Charlton, if you were having an anesthetic, what are the minimum requirements you would expect?
I'd probably want no pain, no recollection of the surgery, and probably the surgeons don't want me to move.
Yeah, fantastic. So you've outlined the triad of anesthesia there, but essentially, we need to get the patient through surgery with minimal physiological and psychological alteration. Is a very basic thing. We want to keep them safe, both physiologically and psychologically. So the triad of anesthesia, which Emma has alluded to very nicely, is hypnosis or amnesia, analgesia, and relaxation. So the purpose of this is that the patient can't remember, they're asleep, that they're comfortable, and they're relaxed. So I got asked a really good question by one of my medical students this week, which took me a moment to answer. She's probably here today. Was if the patient's asleep and they're not aware and they're not going to remember, why do we need to give them analgesia? I want to put that out to you guys. And everyone except Freya can answer.
It be to do with the development of chronic pain. Like if it's severe acute pain in the post-operative period, they can be predisposed to chronic pain.
That is exactly right. Like severe pain intraoperatively or immediately post-operatively increase the risk of persistent pain at 6 months. And that's, I think, pretty well proven. So absolutely.
Beautiful. So we've got some comments here saying physiological response. So that's exactly right. So we'll get tachycardia and a hypotensive response, which can be counterintuitive to what you're trying to achieve in the surgery, especially if you have lots of bleeding or high intracranial pressure also. And also there's a lot about the pain pathways that we just don't understand. So you probably would have remembered from your first year lectures where there's lots of afferent pathways that go to all sorts of brain centers. This include your hypothalamus, your amygdala, and all these subconscious pain pathways. And we actually don't know what severe unconscious pain can do to you psychologically afterwards. So that's another great reason. And no one wants to wake up in pain is probably, I think, the other big reason.
Yeah, that's right. Hey, so just because you answered that pretty much exactly the way I wanted you to answer that, Emma, again, the reason we have a job is because the instruments we have or the medications we have are extremely blunt. Propofol is great as a hypnotic, but has a lot of other problems. Same with the analgesics, same with the relaxants. What are the problems that we have to then solve, Emma, if we give hypnotics, analgesics, and relaxants?
Do you mean like after you give each one, or
Yeah,
just in general?
exactly. Like if I gave propofol, it's great for making you sleep, but it does these other problematic things.
I think I know that some of them might cause lowered blood pressure.
Absolutely. In
But that's all I really remember. Yep.
Almost all our agents cause hypotension and decreased contractility. I'll ask someone else as well. What else goes wrong because of my anesthetic, because my drugs just aren't good enough? William Fong, what do you reckon?
Probably loss of reflexes or and respiratory depressions.
Fantastic. And so essentially, I'm giving these really great things to help the surgeon and help my patient not be in pain and asleep, and they just stuff everything else up. So you're absolutely right. The major things are decreased cardiac output, decreased blood pressure, loss of airway reflex and apnea, and therefore I need to do all of these things, every single anesthetic to keep the patient safe, intubate, ventilate, and maintain cardiac output. And that's why we get very, very good at resuscitation, because we're artificially practicing this time and time again. Which makes it really good, because I remember everyone's got a pretty traumatic rotation in their early years. And I had one rotation where literally every patient was just being met called every day. And the anaesthetist and ICU doctors would just come in and just, as if nothing mattered. And I thought, I want to be that person where they're just so relaxed with these really horrendous things. And so that's what we get to practice time and time again. So our solution, highly trained anesthetists to solve problems, intubate, ventilate, administer inotropes and vasopressors, monitor all this stuff. And then, yeah, many other things. We're going through a series of basic medications on our podcast. So, hopefully on your drive to work, you could just listen to these before your anesthetic rotation and just get a feel of the essentials for each of these medication classes: volatiles, IV induction agents, opioids, paralytic agents, local anesthetics, and vasopressors. Okay, over to you, Kaz.
Just muted
that. Oh, sorry.
So we have a patient here. So this lovely gentleman has a high BMI of 51. He's about 190 kilos. He's got a big bushy beard, and he looks unwell. He's working really hard to breathe and just looks very pale and unwell. His blood pressure is 82/45. That was done 2.5 minutes ago. His heart rate is 140, so it's tachycardic. His rest rate's 35, so it's tachypneic. But his sats are about 98% on 2 liters of nasal prongs, and he's got reduced GCS. Number doesn't really matter. It's reduced. He's a bit obtunded. So that top bit was our ABCDE assessment. So we'll move on to the ample assessment, and I want to we'll quickly run through it. So he's allergic to cefazolin. That's pretty obvious. Don't give it. Now his medications, he's on antihypertensives, beta blockers, and metformin. What could be the relevance of that, Christopher?
So considering this patient has quite a low blood pressure, I'd be concerned that potentially antihypertensives could be further worsening this scenario. His heart rate he is tachycardic, so the beta blockers may not be having too much an effect there. And given that he's on metformin, I'd be worried that he's also a diabetic. So that could also impact on our management moving forward.
That's fantastic. That's pretty much perfect. I have nothing else to add there. So in terms of past medical history, he's got ischemic heart disease. He's got heart failure. So let's say it's heart failure with reduced ejection fraction. He's obese, and he's a lifelong smoker. Kiran, what could be some of the relevances here?
So considering he's got ischemic heart disease and heart failure, I'm assuming he's probably not as robust as you'd like him to be, which means some of your drugs could be harmful for him that you're going to give him for anesthetic anyway. Smoking as well, his lungs probably aren't in a great condition. So managing his SATs, you probably have to keep a close eye on those.
Excellent. So now you've done a fair bit of anesthetics, Kieran. So is this a patient, would you say, a low risk, medium risk, or high risk based on the information here?
Definitely high risk.
Excellent. Good answer. In terms of L, he's had macros on the way here, so high risk of aspiration. And in terms of his lead up to events, he's had worsening small bowel obstruction symptoms. He's previously had the same thing due to likely adhesions due to previous surgery. Good. So let's go to the next slide. Take it away, Larry.
Yeah, so induction intubation, again, what we're going to go through in future sessions is how each thing that we find specifically changes the management. We'll give you these frameworks for that. Essentially, he's a difficult airway because of various reasons, like the fact that he's got a beard and he's got a high BMI, and we do a whole airway assessment on that. Our induction has to be very specific induction, and we'll go through the different induction frameworks depending on what difficulty they have. And then we go through various things to support ventilation and circulation. And again, we use these medications. Like, for example, I wouldn't use the standard propofol induction in this patient. I'd often just use ketamine, midaz, and a really big dose of rocuronium because that's more cardiostable than giving propofol. Someone who's already got a small bowel obstruction is probably septic and their blood pressure is low and they're under volume, needing an urgent lipotomy, will absolutely tank their blood pressure if I give them 200 or 300 of 200 of propofol, which might be a standard dose for this heavy gentleman in any other situation. Like let's say they had an elective operation, but we'll definitely go through more of that. So what we're going to do before our sessions, we'll often give you one of these kind of airway assessment tutorials beforehand, so that by the time you come to the tutes, you'll be essentially, the classroom's reversed. You've done the homework before we go into the classroom, and then we just talk about the interesting stuff. And I find that a really good way of getting the higher level discussions, because again, a lot of this stuff is actually not too difficult. Once you're in the anesthetic rotation, I want you guys to be able to impress wherever you are to try and get a head start in those rotations.
Excellent. And if you're interested in the specifics of those drugs, our podcast, we actually go into it in a lot of detail, and we can build on that in future sessions, as Lars said. So this patient needs to be intubated. Again, this is this could be a 10-hour talk in and of itself, but the principles, I think for those of you who might not have much experience, is basically the point what we want to do is to get a tube from outside into the trachea. So in humans, this is really challenging because, as you can see, there's essentially a right angle between the opening of the mouth and the entry into the trachea. So this is the entire reason why we exist, and also why we have laryngoscope. So that middle blade there is the laryngoscope. So we slide it into the mouth, past the tongue, into the vallecula, which is the space behind the epiglottis, and we pull it up, and you can then see the entrance into the glottis and the trachea. Now, really interestingly, we actually got to go to Werribee Zoo and hang out with the veterinarians there, and we got to intubate a dog. So dogs, being quadrupeds, have essentially a straight axis from the opening of their mouth to their trachea and to the airway. So they're really easy to intubate. So you just literally pull their tongue down, they tie down a piece of string to their teeth, pull their tongue down, and they just put the tube in. So if we were four-legged animals, I would not have a job. So we have a video here that we made last year, which kind of goes through everything you'd want to know about intubation, from basics to complicated stuff. So definitely have a look. The screenshots are from there. The anatomy of the airway is essentially quite complicated, but basically there's a vocal cords in the middle there, and you essentially want to get the tube through them, and that's a basic principle. And then we grade them from grade 1 to 4, basically depending on how much of the glottic opening you see. So grade 1, you see 100%, grade 4, you see nothing. Statistically, if you have positioned the patient well and you have good technique and done by an experienced operator, about 90% of patients in a population are grade 1. And then the trickier the grade is, the less of the glottis you can see, the more complicated and the more fun toys we get to play with to try to get that tube in. And we'll definitely talk a little bit more about some of those, some of those techniques a bit later.
So don't be disheartened. In your first week of anesthetics, every grade will be a grade 4, and you'll think, wow, what was Kaz saying? 90% was going to be grade 1. This just definitely isn't it. Yep, so here's the intubation video. Again, go through a lot of detail in it, but it will definitely help you when you first start out.
Awesome. So once you've intubated a patient, they're going to be paralyzed because you need to give paralysis to paralyze the cords to allow them to abduct enough to get their tube in. So now you need to ventilate the patient. So this is such an awesome part of medicine, which is, it's really amazing what we can do. So essentially we breathe for a patient, and if you think about it normally, we normally ventilate through negative pressure. So we create a negative pressure inside our lungs by expansion of the thoracic cage, by predominantly the diaphragm. And what we do mechanically is we positive pressure ventilate. And as you can imagine, this actually causes a whole host of complications that we then have to take into account. And there's, lots of parameters that we would have to adjust to then allow this to happen. This is something we really do want to teach you guys about, but we really want to have the space to let you have a play. And I think Lahiru's video that is put up there on ventilators is a great primer to then build on that information as we do more sessions later.
Cool. So as we progress these cases, again, just to give you an outline of all the different aspects of anesthesia, we're going to go through, a lot of the problems that occur. Often anesthesia and surgery cause tachycardia and bradycardias. So what do we give tachycardias? We give pain relief, we give more depth of anesthesia, potentially beta blockers. What do we do for bradycardias? We give, things to speed up the heart rate, ephedrine, even adrenaline in some circumstances, or atropine. There's quite a few different ways that we can use our inotropic medications to do that. Likewise, hypertension, we give a bunch of agents for that. Has anyone seen any catastrophic hypotensions in theatre yet?
Or even on the ward, maybe, if you're in ED or ICU.
I saw one on induction. I can't really remember all the details of my first week of clinical medicine as well.
Oh, and what do they do about it?
Well, a bunch of about 50 people came running into the room. And I remember one of the anaesthetists took charge and she said, "I'm handling the code." And I think, I honestly can't remember what they gave her, but she pretty much sorted herself out within 30 or 40 seconds. That her blood pressure went down to 30 or something.
That's such a scary occurrence. And I'd say the blood pressure drops to about 60, maybe once every 6 months to a year, which is, good because it doesn't happen that often. But sometimes the patient's just not as well as you thought, or potentially the drugs affect the patient more than you expect. And then something, everyone has to come in and kind of manage that. But yeah, so what we will do is go through some of the common problem solving frameworks that you just won't have learned as medical students, but we'll teach you the 4-phase approach to handling these intraoperative problems. Because that way, once you get into your rotation, you'll have a framework again to handle that. So what would you be most scared about? Isabel, I'll just ask you while you're there. What would you be most scared about if you were under anesthesia? These are some of the other problems that might occur.
I think I'd be scared of being awake, to be honest.
Yeah, absolutely. Now, it's interesting you said that's the top of our thing. Do you know what stuff we use to, prevent awareness under anesthesia?
Well, I know you guys can use a BIS monitor to essentially monitor
Absolutely.
awareness.
And that's this device that goes across one hemisphere of the head, and it measures your EEG activity, combines it into one rhythm, and then takes a proprietary algorithm derived number to tell you the depth of anesthesia, essentially. The funny thing is, that's not the best indicator of lacking of awareness or making sure that you're asleep under anesthesia. The best one is just having your end tidal volatile concentration above 0.7. That's a very, very rigorous, and again, there's been no cases of awareness above 0.7 of a MAC, which is the minimum alveolar concentration that you'll learn about again when we go through the anesthetic volatile section. But also inadequate paralysis, analgesia, and in one of the surveys that one of my directors did back a long time ago, PONV, post-operative nausea and vomiting, was the thing that patients hated the most about anesthesia. It's such a common problem, and the fact that you're feeling terrible and can't eat and just nauseous for so long is just such a problem. So it's funny that definitely awareness is the one thing everyone says, but once they had an anesthetic, most people would say PONV is the worst thing.
And I think just one of the really unique things with anesthesia, which I hope we're articulating, is there's a problem in front of you, whether it be low blood pressure, tachycardia, low heart rate, and essentially the job of the anesthetist is we have the ability to treat that then and there. It's not starting antihypertensive, then waiting a year and then reviewing the patient. It's kind of direct action to either relieve something that you've caused because of anesthetic drugs, or to support whatever surgical complication there is. So if you're someone like me and you get very impatient waiting for things to happen and you like doing things constantly with your hands, anesthesia is great because you're just tweaking so many different variables during even kind of a routine, even like a routine lab collie type of case. And you don't get to play with a lot of these drugs as medical students or even as interns or residents. It's really when you're a quick care resident or an anesthetic registrar. But you would have learned about a lot of these drugs. And when you come to having an anesthetics term, I think one of the things Lahiru is really good at is getting medical students to draw up drugs, obviously under supervision, and having a discussion about the drugs as you're giving them and getting used to giving drugs. Because that's such a unique skill that we do. Hila, we have a question really quickly. So someone's asked, what sort of patients require rapid sequence induction? What features on history and exam would indicate that they would need one?
Fantastic. So rapid sequence induction essentially is putting the tube in to the lungs and inflating the cuff in a really rapid fashion. And that means that imagine there's your trachea as a pipe, the tube has gone in and inflated a cuff, and that means that nothing else can get in, realistically speaking. Now, the reason we do it rapidly in some situations is that the patient might have a full stomach or a risk of aspiration. So imagine if you're, as a normal person, your airway reflexes, even when you're asleep, is intact. So even if you regurgitated some KFC up into your throat, your airway would just close over and stop you aspirating even asleep. But as soon as you give these anesthetic agents, that's not possible. Now, in a standard anesthetic, you give the propofol, you give a muscle relaxant, which probably takes on average, 2 to 3 minutes to work. And in that time, we are a little bit worried that any food from us or any gastric contents from a small bowel obstruction might leak back into the mouth and then go into the lungs. So what we do in a rapid sequence induction is we give the fastest acting agents. Generally speaking, these days is propofol, succinylcholine or rocuronium, and an opioid. And that means that the time from asleep to putting the tube in is about 30 seconds to a minute, which is a very short amount of time. Therefore, the time risk of aspiration is really small. So that's what we use rapid sequence induction for. Essentially, that's the only reason. It's really about aspiration risk. Though people use the term inaccurately for other situations, they may use the term modified rapid sequence induction, which means you're using a combination of slightly different drugs than the original thiopentone succinylcholine combination. And they may say rapid sequence induction because of a difficult airway. But again, these are technically not the right use of the term. Hope that answers your question.
Excellent. So continuing on with Hagrid. So it's your second day on your anesthetics term, and now you're on the pain round. And so Hagrid is now day one post-op, and he's on your pain round, obviously. So the surgical team note on EMR says that he's recovering well, but his pain continues to be a bit of an issue, and it's stopping him from mobilizing. So in terms of pain, in this particular patient, what would our goals be? Why do we care, essentially? How about you, Brendan? Brendan with an E. No, that's right. Thomas Stephilis.
Yeah, that's it.
Hey, mate. How are you?
All right. So, one obvious reason you care is that you want the patient to be mobilizing as soon as possible. You don't want them in bed, potentially developing a clot. And obviously, we don't want patients in pain. So we go do a thorough assessment, get an idea of what they mean by in pain, where the pain is, if it's associated with the site of the surgery or otherwise, because it's very subjective. And I think I'd start from there and see what's been done already for the pain.
Look, top marks, fantastic answers. Those are all great. So let's build on the mobilization thing. Why do you want them to mobilize or be able to take a deep breath and a cough? Why do we care about that?
Sure. So you don't want them to develop, atelectasis or any lung issues following the operation. You don't want them to develop any clots. So presumably there's been some efforts through medication and sort of non-medical means like calf compressions and the like. So obviously them walking though is ideal. So we want to get them to go to the toilet, sitting up on the chair or whatever it might be as soon as possible.
Yeah, look, that's beautiful. So physiologically, the issue with atelectasis and pneumonia is huge. It's not discomfort. It's not just because they have a bit of a cough. It's actually a serious complication. And mobilization, that's so true. So patients that can get out of bed, sit out of bed and walk around, improve and have much better self-reported functional scores as well as pain scores. And there's been a big movement, at least at Western Health, there was kind of something was called like getting out of your PJs or something. It was just a movement to try to get your patients to get out of the hospital gown and put on their normal clothes day one post-op, just to get out of that, feeling really groggy and crappy in bed. And pain's a huge point of that. So I think we have a few people on the chat who said exactly the same thing. So that's excellent. So you have a look on the EMR, and the surgical intern has started Targin 10.5 BD today. So this is what the med chart looks like now. There are new Targin 10.5 BD. There's no new doses that have been given though. It's just been started. And for PRNs, they have Oxycodone 5 milligrams every 6 hourly. The patient's had 15 milligrams in 24 hours. They have paracetamol PRN 4 times a day. Only 1 gram has been given so far. And they also have ibuprofen 400 TDS PRN, and nothing's been given. I want 3 issues with this drug chart from a pain perspective. Happy for anyone to jump in, or we can pick on someone.
I'd probably want to put the paracetamol as regular, as opposed to PRN, because it takes a while to sort of kick in. So we sort of want to have some base level analgesia going at all times. Probably consider that with the ibuprofen as well. And with the opiates, you'd want to give some variants as well, just to make sure bowels keep on moving.
Awesome. That's all really good. What do you think about the oxycodone dose? You might not be familiar with doses, so that's fine. We can help you out if you're not sure, but you can give it a crack if you feel comfortable.
Yeah, no, I'm not really sure, but I guess that would probably be the instant release. So yeah, I'm not really sure. Sorry.
That's right. Someone said not enough oxytocin. I think you mean oxycodone. Yeah, you did. You don't give oxytocin to this patient. So oxycodone is a short-acting opiate medication. So 5 milligrams is pretty standard for someone like him, but 6 hours is probably too infrequent. And for someone of his size, really you should be doing higher doses like 10 or even 15 milligrams if you're comfortable that he can tolerate it. So great. So that was all really good. So first things first, pain, ibuprofen, and then opiates. So who's heard of the WHO pain ladder? And who can climb us through the ladder? Thanks,
Sorry, I just had a quick question, guys. So
yeah.
Day 1 post-laparotomy, would you consider a PCA?
Fantastic. I'm glad you mentioned that, because this patient's probably nil orally. So anything orally is just not going to be absorbed and probably not going to be on it. So yeah, paracoxiv potentially, if they are nil orally, for IV and non-steroidal IV paracetamol and a PCA. And we'll actually get, I'll actually ask you about that later. Actually, ask you now. What are the reasons you would give a PCA?
It's from my very humble, limited experience.
You're good.
I've seen it generally in quite major operations. But in general, I think both the anaesthetist and the surgeons want to move towards oral as soon as possible.
That's really good, Ashwin. You actually mentioned the 2 things that PCAs are used for. First of all, if they're nil orally, you need a PCA because that's the only way you can get high, I guess very efficacious opioids and medications in the patient. And if the patient's expected to be in major pain. So you, generally speaking, we all say, start low, go slow with a lot of medications, but there's some circumstances where you don't need to start low, go slow. This pain is going to be terrible. Rib fractures, major operations, major long bone fractures coming through emergency, trauma, they're going to be bad. You would never just go, hey, we'll start with paracetamol for that, femur coming out of your skin and see how you go. You'd exactly hit them with multimodal analgesic ladder plus PCA, maybe ketamine and a regional block. So that's great.
Gotcha.
So Freya's answered about the ladder. So yep, you start at paracetamol and a non-steroidal, and you can use either non-selective or COX-2 selective agents. And being mentioned, you guys would remember all the details of the prostaglandin synthesis pathway, I'm sure. And then step 2 is you have an atypical opioid. So this can be tramadol or tapentadol. So tramadol has sometimes been called a weak opioid. I think we're moving away from that in the faculty of pain, because atypical opioid. It's got action at the opioid receptors as well as the serotonergic and the noradrenergic pathways. Tapentadol is a newer drug, which has no serotonergic action, so you don't have all those issues with nausea and the contraindications with SSRIs and other serotonin acting agents. And then your third line are really the big boy opiates, so oxycodone, fentanyl, and even morphine. Just a point, IV fentanyl and IV morphine can be used in recovery, ED, ICU. Subcontinent fentanyl should just never be used on a ward. I still see it done very often by quite junior people without really understanding the pharmacokinetics. It's really dangerous. If the patient's in that much pain, they need subcut fentanyl. They need essentially a PCA or a proper pain review from a pain registrar. And fourth step is you add long-acting opioids. So these are sustained release formulations, which act over usually a 12 to 24-hour period. And my approach with these is really to find out how much the patient's needing in the short term in the immediate release formulation, and then calibrate it to then apply as a longer formulation. So the benefit of this is the patient has to ask for pain relief less from the from the ward nurse. Now, once you've done all this, if the patient's pain is still not controlled, you can call the pain reg. But as a bare minimum, this is what everyone should do. Or at least have an attempt at before calling the pain reg. But at any point, you can ask for advice from us or the pain nurses who, some of these pain nurses have been doing this for longer than I've been alive. So they're an invaluable resource and know a lot. So we're going to quickly play a bit of a game. So these are all the brand names for all the opiates that I could think of. And this used to confuse me to no end. So Lahiru, since you've got the gallery on view, did you want to go through and pick on people for each of these? So we can start off with Panadine.
Oh, yeah, sounds good. Okay. Hey, sorry about this. Daniel van der Merwe. I hope I got that right. What's in Panadine, Panadine Forte, and Nurofen Plus?
Panadine, as far as I'm aware, is just Panadol. Panadine Forte's got codeine, or I think both of them have codeine in it.
Yeah, that's right. And Panadine Forte has more codeine. So I think Panadine has just like 8 milligrams or 6 or something like that, and Panadine Forte is 30. Yep.
Yeah. And then Nurofen, the same. It's got ibuprofen and codeine.
Excellent. And how about Evan Mitchell? What do you reckon? What's in Endone, Oxynorm, and Ordine?
I've heard of Endone. I'm pretty sure that's like a opioid. I would go for it's a conventional, like not atypical opioid.
Yeah, it's a conventional, and it's Endone is like the very common oxycodone, and it's one of the few times you'll be more expected to write Endone, but it's such a familiar term. But I think with EMR we've just standardized it to oxycodone immediate release, and same Oxynorm is like the Endone IV equivalent, what we call Oxynorm, but it's essentially IV oxycodone. Ivy Hodgson, how about Ordine, Capanol, Severdol? What's that? What are those?
Of all the things to ask me about, I actually don't know those ones. So
No, that's all right. Hey, how about MS Contin? Or do any of those ring a bell? Rather, I won't specify any of them.
Well, I thought MS Contin was a sustained release drug.
Yeah, MS Contin is sustained release morphine, and Ordine, Capanol, and Severdol are also morphine agents. They just come by these different names. MS Contin is interesting because you can, if someone's got a nasogastric tube, you can't give them OxyContin because that breaks apart the slow release aspect of it. But MS Contin you can. That was when I learned it. Definitely check it because it's been a while since I've done a pain round. But that was as long as the formulation is the same as when I did this. The pharmacists are really useful in telling you which formula is best for which situation. So that's interesting. Cool. We'll go through the others anyway. There's a whole big list here. And essentially, you don't need to know a lot of these because you'll find a few patterns that just work for you. For example, you'll know the usual simple analgesics. You'll know how to prescribe tramadol, and you'll have a little recipe list for that. And then most of you will probably just prescribe orally Endone or oxycodone immediate release, and maybe add on a slow release OxyContin or Targin. And then depending on some specific circumstances, you might introduce morph mix or any other kind of morphine drugs if there's specific allergies or situations, and maybe buprenorphine is a bit more advanced. So we'll definitely go this in our pain section. So I've got a really good question here about neuropathic pain agents. So this is a whole list of agents, including your tricyclic antidepressants and other antidepressant agents, which have some antineuropathic activity, your gabapentinoids like pregabalin and gabapentin, and then other agents such as, you can get so many different creams, capsaicin type creams, even clonidine, and then lignocaine, ketamine as antineuropats as well. Where do agents like clonidine fit in the pain ladder? Yeah, it's very much one of those things where clonidine is one of those drugs that does a few things, but not super efficaciously. It's an antihypertensive, it's an anxiolytic, and it's I guess a weaker-ish kind of pain agent. But then you've got very advanced agents that are also in the clonidine class, like dexmedetomidine, and those are very good blood pressure lowering, very, very powerful sedative agents, and anxiolytics as well. So you can do whole cases like, sedation cases or endoscopy cases just on dexmedetomidine, which is a just very efficacious clonidine-like drug. But again, we'll definitely go through that in more detail. And is there any reason why you prescribe fentanyl over buprenorphine patch and vice versa? They're just very different agents. Fentanyl is a full-strength agonist at the opioid receptor. Buprenorphine is a partial agonist at the opioid receptor. And they've just got very different profiles. I'm not a pain specialist, but I can give you some. So for example, a buprenorphine patch may be used in some situations where they've just got mild to moderate pain, and it's just an easy to dose thing, and it's very hard to overdose on the buprenorphine patch. But likewise, fentanyl is sometimes used for that as well. So I think it potentially depends on the clinician and some evidence that I might not know about, but we'll definitely get you some lectures on that.
I can probably speak to that really quickly, Larry.
Go for it, yeah.
So buprenorphine is a partial agonist. So it's called an agonist-antagonist at the mu opioid receptor. So it's really useful, and it has good opiate efficacy, but it has less side effects of kind of respiratory depression, and significantly, it has less of a risk of delivering tolerance and dependence.
Okay.
Good. So yeah. So what are your options here? So we have a patient who's got poorly controlled pain. So what is your impression of this situation? Whoever we picked on. Jack, with your camera off. No, how about Cindy?
All right, what was the question exactly?
Oh, that's right. So what is your impression of this patient on the pain round? So they're in pain, they're suboptimally analgesed.
Yeah.
What do we do? Like, what's your clinical impression? We need more drugs? Do we need less drugs? Do we need a different modality?
I would say I would just shuffle them around a bit first of all. So kind of like we highlighted before with the drug chart, make the paracetamol regular, maybe make the NSAID regular as well. Change the dosing of the endone, and make sure the patient is aware that they can have it, because they might not even know. So,
great.
And if this patient is day one post laparotomy, also want to consider putting in some higher strength pain relief. And if then again, like we kind of highlighted before, if it's not tolerated, then contact APS and see if they can help out.
Fantastic. That's exactly right. So essentially, we have suboptimal analgesia. They're at risk of persistent pain, and it's going to be a long road to recovery just because of the laparotomy. So we can sit and wait. We can increase the PR analgesia frequency. We can add on a long-acting opioid, or we can give a PCA. Most people would give a PCA, particularly if it's a laparotomy and they might not be absorbing oral medications that well.
I think we've actually gone through this. So yeah. We mentioned how the reasons why you contact the pain registrar and then organize the PCA is a nil oral patient, expected severe pain, and then this extra thing of patient autonomy, the satisfaction levels of having a PCA, not requiring to ask someone, the nurse, to get medications at certain times is just really useful, and patients love it. Really great satisfaction and really good efficacy for pain management with PCAs. And so, yeah, you can give quite a lot of things you can give with a PCA. The most common things will be fentanyl and morphine, maybe oxycodone IV, maybe buprenorphine and tramadol. But if you were to just learn that fentanyl, almost for most regular people, 20 mics, every 5 minutes, sometimes capped depending on the age, and morphine 1 milligram every 5 minutes, again capped depending on the age. So often the caps are like, say, for morphine about 40 milligrams in 4 hours, or 20 milligrams for above 70 years of age is about right. Okay, so this patient obviously having a bit of an unfortunate journey. After leaving the ward, you hear the code blue alarm. The nurse is already doing chest compressions. What are your first priorities in an arrest? Maybe you've seen an arrest recently with a few things that people just rush to do straight away. Anyone who's seen an arrest initially or recently or ever can volunteer.
I've had plenty of arrests in my time.
Yeah, what do you reckon, Curtis?
Paramedic. A big thing that whenever I go into an arrest, especially if I've got multiple people on scene, so if I have a grad, my grad jumps onto the chest getting compressions done.
Mm-hmm.
My partner and I have a work wife and we work quite well simultaneously together. We usually don't have to speak. I usually take an airway. During these times where basics is key, so a simple OPA to start off with, let's get some good quality compressions going. If we've already got access in, but also getting our backup coming, and then we'll have that line ready to go for when we're needing to give the adrenaline if we're needing to.
Yeah, sounds good. And so I think of these very similar things. I want someone on chest compressions. Often in theatre, I just get the surgeons to do it because they're really good at tasks. And every surgeon I've ever taken through, especially orthopedic surgeons, they're just really good at chest compressions. So chest compressions, you get them cycling through that. I get that defib on early. Chest compressions and early defibrillation are the best evidence base for resuscitation. All the rest, not great evidence. Chest compressions, early defib. And then airway, as you mentioned, and IV access and adrenaline, if appropriate. Now, we get asked a lot, what is the actual point of chest compressions? So what is it? What are we trying to do with chest compressions? Anyone can answer?
It's just to mimic the heart, the natural function of the heart, which is to pump blood, circulate blood around the body.
Exactly. No, that's exactly right. Your heart normally does this very well. If it stops, you just do this to mimic it. And it means a lot of things, you're trying to compress the heart from the sternum down onto the backbone. And that way it has a platform to compress against. You want it at a certain rate. And they've done, I think, in vitro studies where about 100 to 120 per minute is optimal for cardiac output. And also you've got to be really mindful of things like making sure that you completely come off the chest to enable the heart to expand again or relax and get blood back in through venous return. And so you're doing that constantly, acting as the heart. Really good evidence for that. And early defibrillation, if your patient's in VF or VT, restarting that very quickly is such a really good evidence-based thing. Airways, if you're capable of doing that, but again, just as Curtis said, like getting a Goodell in or oropharyngeal airway in and doing good bag mask ventilation, seeing a chest rise and fall is fantastic. And even just 2 breaths for every 30 compressions, as what is recommended, still provides enough oxygen to try to get the patient alive again. Has anyone done chest compressions here besides Curtis?
Yeah, I have.
How was that, Freya?
Yeah, it was an amazing experience. I used to be a pool lifeguard, so we just had a patient once, in that setting. It was, you get very, very tired.
Yeah, exactly. And
I didn't do it for very long. Someone took over.
I know that I get tired after about 30 seconds, and they recommend, going for, 2 minutes per cycle. But whenever I'm running an arrest, a minute every person straight back on with another person. And we just try to get no downtime at all. So again, what can you do to help as medical students? Again, we want to give you lots of things in all these shoots, stuff that you can action, stuff that you can do to make yourselves useful and slowly gain experience to overtake over time doing more and more useful things. What are the things you can do to help initially? Because you may not be able to run a defib, you may not be competent managing the airway. Sean Kenworthy, I might ask you if you're around. That's right. Adelaide, what do you reckon? What can you do to help?
I think firstly, I'll just identify that I'm happy to help because I guess if it's my first time, I'm going to be standing against the wall. But yeah, just saying, hi, I'm Adelaide. I'm a med student. I'm available to help if you need me, if there's a clear team leader. But otherwise, maybe grabbing, IV trolleys, access trolleys, or the defib kind of equipment that I think might be useful.
Yeah, that's fantastic. That's exactly right. Again, I love the obviousness of it, mentioning who you are, because I'll always be looking around for people to help with chest compressions, and medical students are fantastic resources, but usually you're young and fit and able to do it. Whereas if I get the smallest, oldest other staff member, it's just not going to be as good. So you can be very helpful doing that. And again, yeah, getting things that they might need. If the defib hasn't arrived, get that. If the IV cannulation equipment, the tourniquet, and then someone's actually added here some really good stuff. So sending bloods, becoming or assisting the scribe, being a runner for things, getting bloods. You may know the rest of the hospital a lot better than other staff members. So you'll be able to run and get equipment from around there. Yeah, and then finding notes, finding the history, getting the bloods ready, getting any other investigations. You can be so useful, especially if you've been in the hospital for a while. A really good point, acute resuscitation plan, because maybe this patient shouldn't be having prolonged CPR. Scribing is an advanced task. Often the senior nurse does that, or one of the senior members of the team, but you can definitely assist by saying, oh, by the way, that happened, and make sure that you write this down, and just offering suggestions like that. That's really great.
So there's a question here about whether you can ever use a machine for chest compressions, and you can. It's called the Lucas machine. I'll post a YouTube link, which you guys can have a look afterwards. It's we use it a lot in cath lab because the patients invariably go into arrest while they're doing like revascularization, so they use it quite a lot.
Such a cynic. But yeah, it's really useful. But there's a lot of problems positioning. It's difficult, and you've got to be on the right spot. And yeah, we generally don't use it in theatre that I've seen. But if it's in cath lab or a prolonged arrest, or maybe even a transfer. Transfer a patient, it can be really useful to have that machine going while you're transferring, keeping the patient alive, literally.
Just adding on to that, it's currently being used quite widely. So for any of you that are in Queensland, QAS is using it. The Haru team, so our high acuity response unit's got it. And there's also the Zoll Auto Pulse as well, which does the automatic CPR.
Excellent. Oh, thanks for that.
Amazing.
So again, I've got some videos here on, if you ever do the ALS course, this is what you'll build up to. We've got one of our ALS instructors demonstrating what ALS with the Australian Resuscitation Council looks like. And again, if you ever do this course, really try to become instructors. It's one thing to do a course, but to then step up and be an instructor is something that's well within what you'll be capable of, even as residents. And I just encourage you even to just go for it. Definitely contact me, ABCs of Anesthesia, and I can give you some documents to help you kind of get up to scratch with that. And then crisis resource management, something that we'll go through again in another session. This is one of the nurse sessions I ran. But all the little things that they're non-technical, so you don't have to have a lot of knowledge about it. But if you just know how to mobilize your existing common sense, it can make every arrest run a lot better. Would you recommend ALS2 course as a medical student or more so an intern? Yeah, look, just because you'll be doing some pretty high level stuff, I think it'll be easier to even try it as an intern. Definitely do it. Whether you get to be an instructor or not as an intern is not a problem, because then you'll be familiar with it, you'll be accredited, you'll get such great knowledge and information out of it. Plus it's all tax deductible and part of your, what is it, continuing medical education allowance. And then a couple of years later, you can do it and try to be an instructor as well. Really, really useful. Hey, so we're coming to the end of everything. There's so many resources. Feel free to take a photo of this, but again, I'll put this this video out pretty soon. There's so many ways you can find out information. And, I've got to say, I hope you guys I hope I get to work with you guys, because often someone will tell me about a resource that I haven't actually discovered before. Life on the Fast Lane, fantastic site. By Chris Nixon and I think his team. And he really started the free open access education space. So really impressive guy who works as an intensivist at the Alfred. Deranged Physiology, lots of stuff about physiology, just written really well. And then Propofology, great website as well. Obviously our YouTube channel, Practical Anesthesia Techniques is, I think, a Massachusetts general anesthetics channel. And again, amazingly well-made videos. Like, you know, the videos I made are just, you know, not great compared to their stuff is so professional, it's ridiculous. Big plug to them. So that's very interesting. And also that's the birthplace of anesthesia. Some books just to get you started. Obviously my ABC of Anesthesia Bootcamp course is really useful for your first kind of more senior rotation anesthesia, but some of these books there are just really useful as well. And then these days, it's not about how much knowledge you have. It's not about memory so much as access. So I want to teach you guys frameworks and then use apps and all these other resources to just be able to get your knowledge on hand whenever you need it. There's going to be lots of skills that you can learn even now. You know, IV cannulation, obviously never give up an opportunity to practice. Priming fluid lines, bag mask ventilation, and other airway skills. Do the ARC courses, go to as many code blues and MET calls as you can, even just sit, you know, press yourself back against the wall and just observe and use the stuff that you've learned through all the other training to, you know, critique it, like in your mind, critique it. Obviously don't be pointing out too many errors at people, but you may be the difference between observing that the sats have dropped again, or the blood pressure is low again, or isn't cycling. You know, being that voice in the back of the room, learning passively can be really useful. And then, you know, active steps as well. And then learning setups, because that can be very helpful. And then a lot of these tasks we've gone through to assist your team, you'll be often the person that knows the patient best because you've focused on one assessment for a long period of time, and you'll be able to gather all this other information that could be really useful for your team. And again, you want to be that extra part. I think a lot of you became doctors to be helpful, and this will be the first step, being able to know all the resources around you. And yep, take home message, and this is definitely what we're going to go through in all the different resources and lectures we give you out there, frameworks, actions, and resources to make yourself as useful and practical as possible. And finally, yeah, evaluation form. So look, I don't usually fill out an evaluation form unless I do it right there. Fill out that form, and at the, so yeah, just use the QR code, fill out the form. And then if there's, at the end, you know, I've got a very good idea about what I want to teach medical students to try and fulfill your curriculum. But if there's other random stuff that you really want some knowledge on, and maybe you're not sure about, or maybe it's just something you're really interested in, please let us know in that evaluation form, because we'll have a really good look at it and make a plan for the next year where we can, you know, do some really good, hope some really good sessions. Good. A good quick, while you're doing that, quick question about ABGs. In med school, we learn the basics, acidosis, alkalosis. However, I was reading Life in the Fast Lane, they're full calculations. At what stage are you expected to use the maths way to calculate expected acidosis? I've got to say, I recently did that because I was teaching arterial blood gases to some of our part 2 specialty exam people. And I've got to say, it's not that difficult to learn. And I'll put up a video on ABGs pretty soon, because I've already just recently recorded one. Life in the Fast Lane is a really exceptional site, and there's lots of good ABG made easy, but it's not that many steps. And if you can read that quickly, again, it'll be very interesting when you have patients who are sick. Your bosses will always ask you these things, and they probably won't even know a lot of these calculations. And trust me, you can learn these very easily. It's just simple maths. I would, yeah, you know, I would recommend doing ALS courses during med school. Yeah, there's different levels of it, and you can do ALS 1 or ALS 2. Depending, I'm not sure the criteria required to start doing the ALS 2 courses. Potentially, you've got to be an intern or above to do that. But there's lots of other, any kind of ALS course, whatever it is, I reckon just do it, because it teaches you the frameworks of keeping your patients alive. And depending on which med school you went to, they may not teach that as well as you need. So I think it's very useful to go outside to do that. Yeah, so we'll definitely run more sessions, especially if you're enjoying what we're doing here. Topics we'll definitely cover: pain management, even procedures, and we'll try to maybe run some local sessions where you can get hands-on on that. How to decide if your patient is safe for surgery is one of the most common questions you'll ever be asked, whether you postpone or proceed. I'll give you a very structured framework for that, which is advanced but so easy to learn. Airway management, definitely. Fluid resuscitation. Fluids is always complicated, but we'll try to make something, you know, again, I don't think there's too much knowledge in it, just a few structures, and you know how to answer any question then. And then problem solving in the theatre and BLS and ALS frameworks, which that would definitely help you going on to doing a course and getting instructor level stuff.
And just to emphasize the last thing Lars said, if you guys have anything you want to work on with us, the whole idea of what we're doing is really to create an inclusive space where we can expand these projects. So if you are part of a student group, or even you by yourself, you want to do stuff with us, hit out, give us an email, contact us directly if you know us. Our goal here is to make it as big and as inclusive, and ultimately do some good out of it. And we really do rely on you guys to know what it is that you want us to offer. It's been a few years since we were in med school.
Beautiful. We'll call it close. Thanks for spending your, what is tonight? Yeah, it's Wednesday night with us. And yeah, we'll see you next time. We'll use that email list to, pretty much advertise a few more stuff. We'll send links out to future courses. Easy.